So we discussed the causes of hyperkalemia. Now some causes of hypokalemia. So hypokalemia can be present in patient study. Remember that in patient with either AKI or CKD or end-stage renal disease, hyperkalemia is more common. But hypokalemia can also occur sometimes in CKD patients because of two reasons. One is gastrointestinal potassium loss due to vomiting and diarrhea due to high urea levels. And the second cause is as the patient with CKD, they are on loop diuretics such as furosemide, so it can also lead to hypokalemia. Though hyperkalemia is common in CKD, but CKD can also cause hypokalemia because of two reasons: gastrointestinal potassium loss and urinary potassium loss due to diuretics. Now again, as we are talking about potassium, so the endocrine cause should be related with aldosterone, and deficiency of aldosterone lead to hyperkalemia, and excess of aldosterone will lead to hypokalemia because aldosterone hates potassium. It causes an increased excretion in the potassium and hydrogen ions. So can anyone tell me two diseases in which there is hyperaldosteronism?
Cold syndrome.
Yes, Dr. Malia.
Cold syndrome and Cushing.
Cushing and
Cold syndrome.
yes, that's right. Excellent. So Conn syndrome and Cushing syndrome are causes of hypokalemia, endocrine causes of hypokalemia. Now, another endocrine cause of hypokalemia is diabetic ketoacidosis. What is the mechanism of hypokalemia in diabetic ketoacidosis? Remember that diabetic ketoacidosis can cause hypokalemia due to osmotic diuresis, to loss of potassium in the urine, because there is hyperglycemia and excess glucose is filtered in the kidney tubule, and this glucose causes osmotic, which can cause hypokalemia.
Could you repeat that again?
DKA can cause hypokalemia through osmotic diuresis. What is osmotic diuresis? In DKA, there is hyperglycemia, and when there is hyperglycemia, so more glucose will be excreted in the kidney tubules. And when there is more glucose in the kidney tubules, it will cause osmotic diuresis, loss of water and electrolytes in the urine. So it can cause hypokalemia through this mechanism. So endocrine causes of hypokalemia include causes that are related to aldosterone, such as Conn syndrome and Cushing syndrome. And the third one is diabetic ketoacidosis. Now, there were drugs that were blocking aldosterone, which will lead to hyperkalemia. Now, some drugs that can cause hypokalemia, they are thiazide diuretics and furosemide. So thiazide diuretic and furosemide can cause hypokalemia due to loss of potassium in the urine. So endocrine causes are due to aldosterone excess. Drugs such as diuretics, thiazide and furosemide will cause hypokalemia. due to loss of excessive potassium in the urine. Now, some GIT causes of hypokalemia: vomiting and diarrhea, can cause hypokalemia as well because of loss of potassium ion in the vomiting or in the diarrhea. Hypokalemia will occur. Similarly, in chronic alcoholics, hypokalemia can occur due to vomiting. So GIT causes of hypokalemia include chronic alcohol, diarrhea, and vomiting. Diarrhea will cause metabolic acidosis because in diarrheal fluid, bicarbonate ions are lost. Loss of alkali mean metabolic acidosis. While in vomiting will cause metabolic alkalosis because in vomiting, stomach acid is lost. So loss of acid means alkalosis. Now some tumors which can cause hypokalemia is villus adenoma. If you remember from the chapter of GIT, villus adenoma is a large amount of mucus diarrhea, mucus secreting diarrhea, and due to loss of potassium ion in the diarrheal fluid, villus adenoma can cause hypokalemia. Now, another tumor which can cause hypokalemia is small cell lung cancer. So, can any one of you tell me which hormones are secreted by small cell lung cancer?
ACTH.
ACTH, yes. So, ACTH and ADH, ACTH and ADH. So, which hormone will be the cause of hypokalemia in both of them? ACTH or ADH? Which one of them can cause hypokalemia?
Increased ADH.
ADH.
ADH and ACTH, both of them will cause hypokalemia. ADH because of syndrome of inappropriate ADH secretion and activation of renin-angiotensin system, and ACTH because you all know that ACTH stimulates the release of steroids such as cortisol and aldosterone. So excess aldosterone is always a cause of hypokalemia. So this was a brief description about the causes of hyperkalemia and hypokalemia. To remember these causes, you need to remember aldosterone and the function of aldosterone. Then you will never forget what causes hypokalemia and what causes hyperkalemia. Now, management of hypo and hyperkalemia. First, we will discuss management of hyperkalemia. Now, hyperkalemia is divided into three categories: mild hyperkalemia, moderate hyperkalemia, and severe hyperkalemia. Mild hyperkalemia, potassium more than 5.5 up to 5.9. Moderate is more than 6 and less than 6.5. And severe is more than 6.5. Now, if no abnormalities on ECG, then the best initial step is to stop the medication. So one scenario is that the person will present to you with mild hyperkalemia with normal ECG. His potassium level will be 5.5 or 5.9 or any value between them. And ECG will be normal. The best initial step will be to stop the medication. So what medication can cause hyperkalemia?
AC inhibitors, ARBs, and spironolactones.
Yes, that's right. Three drugs can cause hyperkalemia: ACE inhibitors, ARBs, and spironolactone. So if a patient present with mild hyperkalemia and he is taking these drugs, then you will stop the medication. And if a person present with moderate and severe hyperkalemia and with ECG changes, so moderate or severe hyperkalemia with ECG changes, what are the ECG changes of hyperkalemia? ECG changes of hyperkalemia is
Salt
salt-content periods. Yes.
cures.
So the best initial step in this case will be IV calcium gluconate or IV calcium chloride. Both of them can be the right answer. So if a person present to us with moderate to severe hyperkalemia with ECG changes, then the first thing that we need to do is to protect the cardiac membrane. And how we can protect the cardiac membrane? We can protect the cardiac membrane by giving calcium gluconate or calcium chloride, because calcium ions are membrane stabilizer, or they stabilize the cell membrane potential. So the initial step will always be to protect the cardiac membrane by giving calcium gluconate or calcium chloride IV. The next step would be, now we have protected the membrane. Now we have two strategies, either to push the potassium ion intracellularly. Now there are two drugs that can push the potassium intracellularly. One is insulin and the other one is salbutamol. Beta agonist can also push the potassium intracellularly. So the second step would be to push the potassium intracellularly, such as by giving insulin. And as insulin can cause hypoglycemia, so along with insulin, it is important to give dextrose water for the treatment of hyperkalemia. And the second drug which can cause or which can push the potassium inside the cell is salbutamol. So nebulization with salbutamol will also push the potassium inside the cell. So a person presented to us with moderate to severe hyperkalemia, and we are done with these steps. But remember that these drugs such as insulin and salbutamol will push the potassium intracellularly just for a few hours. After 4 to 5 hours, this potassium will come out again when the effect of insulin or salbutamol is decreased. This potassium will come out of the cells again. So shifting potassium intracellularly does not reduce the total body potassium. So that's why we need to do something to remove this potassium from the body. So in first step, we protected the membrane. In second step, we push the potassium intracellularly to buy some time with and glucose and also with salbutamol. So in third step, we will try to remove the excess potassium from the body, and that can be done by giving IV fluids if the patient is not in fluid overload. Remember that you cannot give IV fluids such as normal saline to the patient who are in fluid overload. So can anyone tell me what are the signs of fluid overload, signs and symptoms of fluid overload from the cardiology chapter? Recall from cardiology chapter, what are the signs and symptoms of
Hyponatremia,
hyponatremia?
and
Septal edema,
intracranial edema, brain edema.
Intracranial, no, the sacral edema and crepitations at lung bases, shortness of breath.
Yes, when there is excess fluid, Dr. Shafraz, you want to say something?
I was just going to say pulmonary edema.
Yes, the most important one is whenever there is excess fluid in the body, the first organ that will be affected is heart. So don't forget that because heart need to pump the blood. So if there is more fluid in the body, the first organ that will be affected is heart. So what will happen? The heart will be unable to pump the blood. The fluid will accumulate in the lungs. And the sign and symptoms of fluid in the lung is on auscultation, there will be crepitation on the basis of lungs and also pedal edema, accumulation of fluid in the peripheries, and also there can be ascites. So two important signs to remember for fluid overload is pulmonary edema, which will manifest as orthopnea and shortness of breath, plus on auscultation there will be bibasal crepitation and pedal edema. So if there is edema, then you will avoid IV fluid or normal saline as a management of hyperkalemia. So we were discussing management of hyperkalemia, and we can remove the potassium from the body. So the only method by which we can remove the potassium ion from the body is to promote the urinary potassium loss. And how that can be done? That can be done by giving the IV fluids plus diuretics such as loop diuretics, because we have just discussed that loop diuretics can cause hypokalemia. Thiazide diuretics can also cause hypokalemia, but they are not used in emergency situations. Loop diuretics are preferred in emergency situations. So to promote urinary potassium loss, we will give the patient IV fluids plus loop diuretics. But if the patient is well hydrated or overhydrated, or if the patient is in fluid overload, then we will not give IV fluid, we will just give loop diuretics.
Can you repeat that? How the potassium is brought back into the extracellular space? I mean, like the process.
So the management of hyperkalemia, the first step will protect the cardiac membrane, and the protection of cardiac membrane is done through calcium gluconate and calcium chloride. And the second step is that we can push the potassium inside the cell. And there are two drugs which can push the potassium inside the cell, and that is insulin and salbutamol. But the duration of action of insulin and salbutamol is about 5 to 6 hours. So after 6 hours, the potassium that was pushed by these two drugs inside the cell, they will come again out of the cell. So that's why we need something to excrete the potassium from the body, and that can be done through urinary potassium loss. And what we can do to promote urinary potassium loss, we have a drug that is called loop diuretic that can be given to promote the potassium urinary loss in the urine. So there are two methods, or there are two scenarios. One is the patient is well hydrated and or he is in fluid overload or heart failure. In this scenario, normal saline, we will only give loop diuretic at a high dose. And if the patient is dehydrated, then we will give normal saline along with loop diuretic.
Okay, got it. Thank you.
excess potassium from the body, that is calcium ammonium. But the onset of action of calcium resonium is very slow. At least it take at least 2 to 6 hours to start removing the potassium from the body. And the last step is that we can give a drug which is known as K-aguolate, which comes in a powder form, and it will bind with dietary potassium ions. So it will decrease the absorption of potassium ion through enteric tract. K-oxalate powder. So this was all about the management of hyperkalemia, stepwise management of hyperkalemia. What if the patient with hyperkalemia and ECG changes, if the patient present to you with hyperkalemia and ECG changes, and he is having oligouria or anuria, then hemodialysis will be the best step in the management of such patient. So a patient with hyperkalemia, what are the indications of for hemodialysis? If the patient is anuric or oligouric, because in such cases, if the patient is having anuria or oliguria, the use of diuretics is not going to work because the person is anuric. So we cannot promote urinary loss. So the only option that we'll have after giving IV calcium gluconate or calcium chloride is hemodialysis. So this is one indication for hemodialysis, and the other indication for hemodialysis in hyperkalemic patient is that if hyperkalemia is refractory to treatment, even if after all these steps, the patient potassium levels are still high, then again we will go for the last option that we have is hemodialysis. So what is the dose of insulin and dextrose water? Usually 10 units of insulin in 50 ml of 50% dextrose or glucose solution are given over 30 minutes. So this was all about the management of hyperkalemia. Is it clear to everyone? Does anyone have any question? No questions?
Well, just one question, like in the option, for example, if there are no ECG changes and the option says about calcium gluconate, are we supposed to give calcium gluconate at that time, or we just find out the cause of hyperkalemia first?
Yes, if there are no ECG changes, then there is no need. The indication for giving a calcium gluconate is ECG changes with hyperkalemia with ECG changes.
Okay.
Remember crackles at lungs or crepitation at lungs and sacral edema. You will always think of heart failure. In such condition, we will not give IV fluid. We'll only give diuretics at high doses. Now, management of hyperkalemia. Causes of hypokalemia included endocrine causes of hypokalemia.
Cons disease, Cons syndrome, Cushing, and decay.
Yes, that's right. So one word answer for why how DKA cause hypokalemia.
Osmotic diuresis,
Excellent. So endocrine causes of hypokalemia include on and DKA. GAT include vomiting, diarrhea, and chronic alcoholism. And there is one more cause, which is a renal cause, that is Bartter syndrome. We'll discuss Bartter syndrome in the coming slides. For now, just remember that in Bartter syndrome, there is a genetic defect in the 1 sodium, 1 potassium, and 2 chloride ion channel that is present in the loop of Henle or ascending loop of Henle, ascending limb of loop of Henle. There is genetic defect in the 1 sodium, 1 potassium, and 2 chloride ion channel. There is no absorption of 1 sodium, 1 potassium, and 2 through this channel, which will lead to hypokalemia, severe hypokalemia. So add this to the causes of hypokalemia as well. Now a person with hypokalemia can present with weakness, leg cramps, and U wave on ECG. U wave on ECG is a very specific hypokalemia. Let me show you a U wave. See in ECG that this is P, this is Q wave. The first negative wave is Q, which is not normally present on a normal ECG. This is the first positive wave is R wave, and this is S wave, and the junction of SD segment and S wave is, or QRS complex is J point. Now after QRS complex there is T wave, so PQRST, and the wave that is present after the T wave is U wave. Can you see this small wave that is present between T wave and P wave? This wave is known as U wave. This is called U wave because of this sequence PQRSTU. So the wave that is present after the T wave in patient with hypokalemia is called as, or is known as, U wave. So it is a very specific finding for hypokalemia. Another ECG. See, this is a normal ECG in which Q wave is not present, just R and S wave, and then T wave, and then this one is P wave. And you can see that after T wave, a small wave present just after the T wave, and this is U wave. Here and here, you can see it. So ECG finding of hypokalemia is U wave. Other ECG findings such as T wave inversion can also be present in the hypokalemia, but the more specific change, or the change that is only present in the hypokalemia, is U wave on ECG. So what is mild hypokalemia? Mild hypokalemia is if the potassium level are less than 3.5 but more than 2.5. And severe hypokalemia is if the potassium levels are less than 2.5. Remember that severe hypokalemia is managed by giving IV potassium chloride, while mild to moderate hypokalemia is treated with oral potassium supplements. So severe hyperkalemia, level of less than 2.5 or potassium level less than 3 with ECG changes. We will treat with IV potassium chloride. Whenever there are ECG waves or ECG present either in hyperkalemia and hypokalemia, we will as an emergency situation. And oral drugs are gonna take some time to produce their effect. So in such cases, we will use IV potassium chloride. If ECG changes are present and even the potassium level is more than 2.5 and less than 3, then we will go for IV potassium chloride, otherwise oral potassium supplements. And again, remember that sometimes in the Plab exam, they will ask you about a question that which electrolyte need to be monitored or which investigation you need to order in a patient with hypokalemia who is not responding to the treatment, then your answer will be magnesium, because magnesium in a patient with hypokalemia, remember to order magnesium and ABGs, because as I already told you that metabolic acidosis can cause hyperkalemia, because whenever there is extra acid in the body or extra hydrogen ion in the body, the hydrogen ion are pushed intracellularly and in return potassium comes out of the cell. So the opposite will happen in alkalosis. So whenever there is alkalosis, hypokalemia will occur, because to compensate alkalosis, hydrogen ion comes out of the cell and in return potassium ion goes into the cell. So because potassium is going into the cell, so the patient will develop hypokalemia and alkalosis. So two investigations are important to do in patient with hypokalemia, and that is magnesium and ABGs. Magnesium to exclude hypomagnesemia and ABGs to exclude metabolic alkalosis. Why it's important to order magnesium levels in patient with hypokalemia? Because magnesium helps transport calcium and potassium ions in and out of the cell. So if there's deficiency of magnesium, the transport of potassium will be disturbed and the patient will not respond to the treatment with the potassium supplements, because potassium require magnesium ion for the transport of itself. So that's why don't forget to order magnesium and ABGs in patient with hypokalemia. So this was all about the management of hypokalemia and which things we need to monitor in hypokalemia. Is it clear, everyone? Is there any question? Okay, no question. So our next topic is Bartter syndrome, which is a cause of hypokalemia. The mechanism of action of loop diuretic is that it acts on the 1 sodium, 1 potassium, and 2 chloride channel that is present in the loop of Henle, in ascending limb of loop of Henle. That is why they are called loop diuretics. So Bartter syndrome is just like, you can imagine that it's just like loop diuretics. Just like if the person has taken high doses of loop diuretics, because there is a genetic defect in the 1 sodium, 1 potassium, and 2 chloride ion channel, due to which potassium ions are not absorbed and they're excreted in the urine, which will lead to hypokalemia. Bartter syndrome usually presents in childhood, which is known as classic Bartter syndrome. And the presenting feature is failure to thrive. Another type of Bartter syndrome can also be seen in the neonates as neonatal Bartter syndrome because there is a genetic defect in the ion channel that is present in the ascending lobe of Henle. So it will lead to an excess loss of electrolyte and water, which will result in polyhydramnios. So Bartter syndrome can cause polyhydramnios. And after birth, the child usually present with polyuria and polydipsia. So polyuria and polydipsia is also a feature of diabetes insipidus, but in diabetes insipidus, there is no hypokalemia. So Bartter syndrome will present as polyuria, polydipsia, failure to thrive, etc. The main problem is that loss of salt and loss of electrolytes and loss of fluid. So the treatment depends upon the electrolyte abnormality. The treatment usually consists of sodium chloride and potassium supplementation, and sometimes spironolactone can also be used because spironolactone will reduce the potassium loss, and also increased water intake should also be advised in the management of Bartter syndrome. In severe cases where supplementation with sodium chloride and potassium supplementation alone cannot help the disease, in those cases we can use NSAID, non-steroidal anti-inflammatory drugs. You all know that non-steroidal anti-inflammatory drugs, they reduce the glomerular filtration rate because they decrease the synthesis of prostaglandins. So they reduce the glomerular filtration rate. So in severe cases, NSAIDs can also be used. Also, ACE inhibitors can also be used. This treatment is not going to be asked in the Plab 1 exam, but still it's very easy, so you can remember it. So this was all about hypokalemia and its causes.